record. Henry, nice to see you on this sunny afternoon, and thanks very much for coming to speak to us today on The Sport Doctor. Tell us a little about your yourself and where you come from. It's like Cilla Black, this, isn't it?
Thanks, Justin. Well, thanks for having me, particularly for one of my favourite topics. So I am a specialist knee surgeon. I have a full-time NHS practice at Frimley Health, which is just outside London. The practice is at Wexham Park and Heatherwood Hospitals, which really covers South Buckinghamshire and East Berkshire. I have a special interest in soft tissue knee surgery, having been fellowship trained in 2 excellent soft tissue knee units, sports knee units in Australia. I've been in practice as a consultant for around 8 years now, and I really enjoy and I'm very passionate about looking after sports knee injuries.
Well, and I'm really, really pleased to have you here today. So we've got a couple of talks and we're going to split them up just so they're a little bit more bite-sized and manageable, because there's a lot of brilliant information in each of those. And we're aiming this at our colleagues, our HPs, physiotherapy, junior docs, anybody who's interested in sports medicine. Then I think there's something in these talks for you. So first of all, Henry, tell us a little bit about that one.
So the talk, first of all, mainly focuses on how the knee gets injured, and then why the knee gets injured, and then what to do when it immediately gets injured. And we'll focus to start with on the most common ligament injury, which is the anterior cruciate ligament. And then the second part, as you say, is a little bit more technical. Those people that like surgery, want to get into surgery, or are just interested in what we do. The surgical techniques are in the second one.
Sure.
So I will start, if you allow me to screen share.
Sure.
And I can load up my slides, because I think it's quite nice to illustrate it with pictures and the important points. And I'll talk you through it, and do feel free to stop me at any point, and
Perfect.
and we can chat. So this is really the overview of the talk. I'm going to talk about the importance and why knee injuries are important. We'll focus to start with on the anterior cruciate ligament, and I'll talk about why that's important. And then, as mentioned, the more surgical bit comes later in the second part. So what is the importance? Why do I have a full-time practice treating knee injuries? Well, it is the most injured joint in the body. The incidence is extremely high. It's nearly 2.3 in 1,000 people will have a significant knee injury. As you well know, in 2021, there's a huge demand for sports and exercise, right from youngsters right up to much older patients doing very high levels of sport now. And this graph on the right from the British Journal Sports Medicine shows very well that if you look at the incidence of post-traumatic osteoarthritis, so wear and tear in the knee, you'll see that from the time in years from the index date of injury, the different injuries here, the incidence goes up of post-traumatic osteoarthritis. And the one right at the top there is the anterior cruciate ligament. So these injuries cause a problem for the knee in the future. People always ask me, why does the knee get injured? Well, if you look at where the knee sits, it sits between these 2 long bones, the femur and the tibia. They are the 2 longest bones in the body. And the forces created by the lever arms of those 2 long bones is very, very high at the knee, which is why it gets injured. The anatomy of the anterior cruciate ligament, which we will focus on to start with, is developing all the time. What has been around for millions of years has only really been studied in detail recently. These beautiful pictures come from a Polish surgeon called Robert Smigelski, who's done a lot of work on this. And there is no question in most of our minds that the ACL is divided into 2 parts. Whether it's a ribbon or 2 bundles is still up for discussion, but it certainly appears to be in 2 parts. Its control, as I will show you in the middle of the talk with the mechanism, is related to controlling the tibia, the movement forwards on the femur. So my bottom hand is the tibia, my top hand's the femur, and really its major function, the anterior cruciate ligament, is to stop the tibia moving forward on the femur.
So where you do that again, Henry, with your hands. So on your T, so you're with there. So effectively, the anterior cruciate ligament would be attached to your knuckle. That's
right. I'm going to show you a green piece of ribbon. The anterior cruciate ligament. It's in the middle of the knee. Ignore the bits at each end. Focus on the bit in the middle. And as the tibia moves forward, the ligament, which is the green bit between the two, is preventing it from going any further. So the ACL tears quite frequently in sport, and we look at different groups of people, and it is interestingly more common in ladies, but we see more in men because there are probably more men doing sport than women. However, the incidence in ladies, as you can see, is very high. We see groups of patients, and in males, it's 13 to 18-year-olds are a similar incidence to the girls. Then there is a definite peak in males between the ages of 17 and 25, and then a smaller peak later on in life, both in males and females, particularly in females. And these are often people who are returning to sports after bringing up a family. We do see this in children. It's rare, but we're increasingly picking them up. I think there were always injuries in children, but I think previously we didn't see them as much. So how does it happen? Well, it depends where you are in the world. In East Berkshire and South Buckinghamshire, I see really most of my injuries in males from football, and I see most of my injuries in females from two sports, netball and skiing. It happens in rugby, it happens in martial arts, it happens in all different types of pitch or environment. But you can see there 70% in males comes, in my practice, comes from football, and about 80% of those two sports mentioned. Now, the mechanism is a very interesting part of this, and people often assume that the only time you get a serious knee injury is in collision, in contact. But actually, the most interesting thing about ACL tear is that 75 to 80% are non-contact. People will assume that if nobody's touched you, you haven't had a collision, you can't have injured your knee seriously. But that is really not the case. We see two things. We see a landing injury, and we see the classic sidestepping injury. One of the things that causes ACL tear is the sidestep, as many of you will know, and it's often to do with how good the interface is between the shoe and the surface. So netball courts, particularly where the shoe grips very well on the court, the body goes one way and the foot stays planted. So we've mentioned the twisting injury, but there's also another fascinating injury which has been well described by one of the world's leaders in ACL surgery, Don Shelbourne, who's in Indianapolis. And he described very eloquently the mechanism of landing. And landing is a very common cause of ACL tear. And I will show you with my hands again what happens on landing.
Henry, just come out of the screen share, just so it's because most people would be watching this on a phone, and it'll be a tiny little video. Come out and just so it's on, you're on at least on full screen. That's perfect.
So Shelbourne's mechanism is a landing of a straight or nearly straight knee. Now, as the player is coming down from landing, what you're doing in your brain is you're anticipating when your foot hits the floor. Now, if the anticipation is out by a fraction of a second, the quadriceps contracts to stop you falling. And when the quadriceps contracts, the tibia begins to sublux forward. Now, if that happens before the landing, when you do land, what happens is you land on the sublux tibia and the knee rotates, internal rotation of the tibia, and the femur, my top hand, falls off the back of the knee because of the posterior slope of the tibia,
Okay.
and thereby almost dislocating. And if I put the ligament in with my green tape again, what's happening as it subluxes is that the ligament has no chance of remaining once the subluxation and dislocation occurs. And that is where it goes from its functional position to a non-functional position, and the lever arm is then causing the force to go through it to tear it.
That's why we see that sort of those kissing lesions on the MRI scan, that bruising at the back of the plateau and the condyles.
That's right, and I can show you an MRI scan of that later, but you're absolutely right. On the lateral side of the knee, the dislocation causes the femur to make an abnormally large bruise on the tibia in a place where it shouldn't be. Once the ligament snapped, it subluxes further back. Moving on from the mechanism, the next thing is any healthcare professional, anybody involved in sports injuries, the history is absolutely key. And I would say that in my practice, I would probably diagnose 70% of these injuries before I get to examine the patient based on the history. And there are some really, really relevant things in history. And having described the mechanism to you, I went to change direction and the knee gave way. Now, in a young person on a sports pitch, for me, that's an ACL injury until proven otherwise. The skiers, the ski didn't come off is the most important part of the history. The force created by the length of the ski, the twisting injury on the knee is so huge, the ACL often has no chance. So if the ski didn't come off, it's an ACL rupture until proven otherwise. The other thing you'll hear time and time again, particularly from the youngsters, is that they've had a previous injury which got better after a few weeks, and then it happens again on the sports pitch because they think they've got back to normal. And now it doesn't feel right. There is often a pop or a snap, but often there isn't. The knee swelled straight away is often a sign, but often we don't get that as well. So while these things are important, it's a question of putting it together. And the key point I want to make, particularly with the youngsters, is that although it hurts for the first few days, these teenagers get better incredibly quickly, and you can rupture your ACL and you can be almost back to normal again in 2 to 3 weeks when you're age 16, 17, 18. So often the reason these get missed is because of how quickly they get better.
And why is that, Henry? Why would the pain, because it seems quite a significant ligament injury. Why would the pain suddenly go so quickly?
I think that what happens is that when you tear your ACL, there's a blood supply to the ACL. There are blood vessels in it. And when you tear it, the knee bleeds. And there are lots of nerve endings in the ACL. And I think once it's snapped, it functions and those nerve endings are no longer giving pain. And I think then once the blood goes, the swelling settles. The knee then is essentially not damaged anymore. The ligament's gone. There is still some bruising off on the back of the knee. But as you know, in teenagers and youngsters, bruising for them gets better in a couple of weeks. So they get better really quickly. So moving on to examination, there's been various studies done about this in various clinics around the world. And there's lots of different ways of examining for ACL tear. But of the studies that have been done, the two most sensitive, the two that will pick up ACL injuries most often are the Lachman test and the pivot shift. And I will show you both of these in more detail. But the examination is absolutely key. It really, really is, because you have to rule out injury to the other structures. And that will lead you to the diagnosis and the management. So if we look at the two tests, and I think I've got them the wrong way around, so I'll go with the Lachman test first. The key to the Lachman test is looking at the video on the right-hand side, is if you watch my upper hand, the upper hand should not move. What you're doing with the Lachman test is you are looking to see whether the tibia will sublux forward. So looking at it again, the femoral hand should stay very still, and the tibial hand comes forward gently. And that is how you make the diagnosis with the Lachman test. And it's very, very sensitive if you do it. But I remember training to do this when I was in Australia. And the chap who taught me did say it will take you 500 of these before you get good at it. And he was right. It really is practice. So those of you that are learning to do this, don't give up, just keep going.
And roughly, Henry, I see you've got the knees there in around sort of 20 degrees of flexion. Is there an optimal level of flexion that you should have?
20 to 30 degrees. You have to bring it out of extension to do it, because in extension there are other structures stabilizing anterior translation of the knee. So you're taking those out of the equation. So yes, absolutely right.
And one of the ones that I guess we sort of taught at medical school is anterior draw. Why do you think Lachman's is preferable, more reliable than anterior draw?
A good question. I think that you get to feel, because the knee is free, you get to feel the anterior translation much better than you do when the foot is planted. I think that you get a much better feeling of just the anterior cruciate ligament. I think at 90 degrees with the foot planted, I think there are too many other structures in play that will give you a false result. Okay. And the other thing I haven't mentioned is you must examine the other knee, because one person's Lachman test is different to another's. So you do the normal knee first, and then you do the injured knee, and you will get a feeling that the two are very different. And then the pivot shift test is difficult to do. And it's difficult to do, particularly when the patient's awake, because a lot of patients won't let you do this because it hurts. And it is important to try to distract the patient as much as possible in order to do it successfully. And generally, unless the patient really likes you, they'll only let you do it once because it hurts, but it does give you straight away an indication that the knee is unstable due to Acl tear. And if I can get this video to run, it is a question of internally rotating the tibia with the leg in full extension, applying an axial load, and you'll see the patient's foot is in my elbow, and a little bit of valgus stress, and you go from extension into flexion, and you will just see the rotation if you watch the patella. And the rotation is happening because the tibia is subluxing forward from an abnormal position into a normal position, and you rotate it and it shifts.
Can you explain that organ again? If we just stop out of that video, because it's a really, I think, a tricky concept to get, is and just explain again with your your F&T hands as to what actually is happening of femur on tibia.
Yeah, it's what you're starting from a position where the tibia is slightly subluxed forward, and as you go into flexion, the tibia drops back into place where it should be. So it's starting from an abnormal position in an extension into and it drops itself back into a normal position as you go into flexion. And that's without the ACL, it is anteriorly subluxed, the tibia, and it flips itself back into a normal position with the rotation and flexion.
That's really helpful.
And then we go on to imaging. Orthopedic surgeons love imaging. X-ray has been our bread and butter for years. There are only very subtle things to see on an X-ray. Really, MRI scan is the gold standard. We use MRI scan to diagnose all soft tissue knee injuries now. So really, if people have had a serious knee injury, they should be getting an MRI scan. It's not as expensive as it was. It's readily available now. I don't get any that information. I don't use CT very much apart from in children. And for me, ultrasound scan has got limited or no place in the diagnosis of this injury. There on the X-ray is something called a second fracture, which was described by a Frenchman. But I see this only really in radiology quizzes and maybe once in 100 times. So this is not a reliable sign, but it is of interest. Here is the MRI scan, and I will take you through these slowly. On the left here is the sagittal. So we're looking at the knee from the side. You can see the outline here of the fibula. So we know we're starting on the outside. And if I run the video, we start on the outside. MRI scan looks at 5 millimeter slices. This is the outside of the knee, femur at the top, tibia at the bottom. There are those bone bruises, Justin, that we were talking about from the dislocation. Okay. Diagnosis is already fairly clear before we've got to the ACL. These are the menisci. And then we look now as we get to the middle of the knee for where the ACL should be. And this is where it should be. And you can see it's torn. As we go through, you'll see its partner, the PCL there, intact. And then there's a very subtle sign at the back of the medial meniscus sometimes, which is a little bit of a split between the meniscus and the capsule. But that's very much, radiological detail. A good radiologist will describe all of these things. From the front, there's the kneecap. We're going through in sections from the front with the middle one here. The white stuff is a big swelling. This is a new injury. And the thing to look for on the outside of the knee are the bone bruises that we discussed. Okay. Here's the bone bruise on the femur. And then as we get towards the back, you'll see the matching bone bruise on the tibia. Just coming in now. So that's where the bruises are from dislocation. And finally, we call this the axial. The axial here on the right-hand side is looking at slices like bread slices. And there's the large effusion. We're going down through the femur here. You'll see the bruises on the femur here on the outside. And then at the back where it's dislocated off, here's the bruise at the back. When you see these bruises, you almost don't need to look at the ACL to know that it's torn. The knee, excuse me, the knee cannot get into that position without an ACL tear. So that's the radiology. We then move on to management. Well, the management actually is the easy bit to start with. People, patients, other doctors, physios phone me, sometimes in a bit of a panic. What do we do? What do we do? Well, the first few weeks, there's nothing to do apart from to make the diagnosis and to use plain old-fashioned ice, okay? Patients do not need a brace if their collateral ligaments are intact. They can have crutches, of course, for pain relief. RICE is what we use in healthcare. You'll be well aware of that for rest, ice, and elevation. Early physiotherapy referral to get the movement back. MRI scan, and then to see me at some point. There is very little to do in the acute phase. Just let the knee settle, get the swelling down, get the range of movement back. Apart from in very extreme cases of elite athletes, we do not reconstruct this ligament in the early phase.
Henry, can I just ask, with when you see those early knees that are like a massive swelling or hemarthrosis, and patient can barely bend the leg, what do you think about under sterile conditions and aspiration of that joint?
There's two types of hemarthrosis, and by hemarthrosis I mean a knee full of blood.
Yeah.
The first one is what 99% of them are, which is a swelling that is uncomfortable for the sportsman, sportswoman, or patient. And ice, anti-inflammatory medication, elevation treats 99% of those. In 1% of cases, it's tight like a drum, and the patient is really visibly in pain. And you go to examine them, and it feels like it's going to pop. I think under sterile conditions, in that situation, you can put some local anesthetic, put a needle in, and you can drain off the blood. And I think it's perfectly reasonable to do that. And the patient will hug you because they'll go from having a painful knee to feeling a lot better. But in my experience, we have to do that very rarely. I think good icing, good elevation early. You'll see these ice packs on the side of most sports pitches these days. And early ice and early elevation prevents the need for that.
And you can order these on Amazon or equivalent online.
You can. You can, and there are these lovely cryo cuffs available that you can keep refilling without having to go to a tap. You know, there's a bucket of ice next to it with a hose. You know, there's some fantastic equipment available for sports injuries now, and as you say, you get it on Amazon.
Okay, thanks.
So moving on to chronic, you know, we'll see quite a few of these. Probably 35% of patients will present chronically to my clinic, and you know, it's very much a case of teasing out when the injury was and then working out how it's affecting the patient. We usually do a workup with lots of other different types of x-rays and making sure that there's no problems above and below the joint with the hip or the ankle perhaps. Examine and then work out with the patient, you know, what to do. The thing I want to know most is, why is the patient suddenly presenting? Or do they have a problem? We use this term in knee surgery, functional instability. And really all that means is that the patient is having a problem with something they're doing. Now, it doesn't have to be sport. You know, you may see somebody who climbs a ladder for a living with an unstable knee because of an ACL tear on his ladder or on the roof, or doing part of his or her job. And as a result of that, functional instability is a reason to consider reconstruction. Now, people ask me always, and it's very, very important for a surgeon not to say to patients, you know, you must have an operation. I think there is, most of the time in knee surgery, an option to go down the non-surgical route. This hasn't been studied that well. This is the only available prospective randomized controlled trial of comparing patients who have surgery with patients who don't have surgery. And it's a very reasonably small number of patients. And what they looked at was, they looked at a group that had the reconstruction, and they looked at a group that didn't have the reconstruction to see how they did. Now, it's very important that if you do go down the non-operative route, that you have intensive physiotherapy. In my opinion, if you have an ACL tear and you don't go down the physiotherapy route, you don't tend to do very well. Now, they looked at outcome measures. These are knee outcome scores here, and they followed the patients up for about 5 years. And interestingly, there was no difference between the two groups in patient-reported outcomes at 2 and 5 years. So there was no difference between them. However, what is very relevant is that half the group that did not have the initial surgery went on to have either the reconstruction later or surgery for some sort of other problem related to the knee. And what we know from that is, we know that knees without an ACL get injured more frequently than knees with an ACL. And so the basis really of reconstruction is about not return to sport, it's about prevention of re-injury.
One question with it, Henry, is I see these patients come into the clinic and they had ACL reconstruction 20, 25 years ago, and they've led a very active, sporty life, but the knee's absolutely trashed from an arthritic perspective. You know, they've got grade 3, grade 4 arthritis. Is there any reason for, if you didn't have an ACL reconstruction, is there any evidence to suggest that you would get more osteoarthritis earlier than if you did?
That's a really, really difficult one to answer, because the problem, as I said, is that there aren't groups of patients that have been controlled, that have been followed through many, many years. And it's always about management. And if you compare groups of patients with the same management, you would get that answer, but you're never going to be able to get that group, because often some of those people that get very bad arthritis will have played a lot of sport. And as you say, they've trashed their knee. Now, if they had the ACL, would they have trashed their knee so much? It's very difficult to tell, because as you well know, good research in medicine, good research in surgery is all about comparing accurately between two groups. And there are always confounders which will take one away. So, you know, that's like a politician's answer to your question. But I think that what I'm trying to get at is that there isn't any long-term evidence about osteoarthritis that is really concrete, but we do have evidence to show that there is an increase in re-injury to the knee in people that don't have an ACL reconstruction. So there is a, research moves on, and every year goes by. There is a current trial going on in the UK, and the hospital I work in is part of that trial. We are recruiting patients to this trial, which is prospectively trying to answer this question.
Okay.
We do not have any outcome data from it yet because it's underway, but we will have that at some point. It's being run out of Oxford. So that brings things to a close, Justin, for part one. I have part two lined up, which is more to do with the surgery and, as we discussed, the other ligaments in the knee. But I'm very happy to answer any questions you may have about part one before we finish.
It is reasonable for some people to try, if appropriate, a non-surgical management, a conservative management route with that. With those patients, let's say someone did choose that and they did fine for a year, and then they start to sort of feel unstable. Does it matter how long you leave it until you did an operation?
It does, if you're not being sensible, and if you're having ongoing instability and the knee's giving way. I think you will be damaging the knee if that happens repeatedly. Those movements I've shown you with my hands, those rotational movements, are abnormal stresses to the knee. And I think that if your knee is repeatedly doing that, I think it is damaging it. If your knee's not doing that and you're sensible and you stick to sports or exercises that are friendly towards that ACL deficient knee, then I think you can wait. And I think people do. And I don't think it's a problem waiting if you're sensible and you know what you're doing and you're being supervised. I think if it's not those three things, then I wouldn't recommend waiting. We do have data to show that the longer you wait, the more or the worse the knee looks inside. There's a very good study from Australia in over 5,000 patients that shows that the longer it is between the time of injury and the surgery, the higher the number of what we call intra-articular injuries.
Okay. Henry, thanks very much for that. It's really, really helpful, very, very informative. You can see on the screen there at Henry Knee. So if you want to follow Henry on Twitter, I understand there is a link tree to Henry's website and any further information that you might want there. But Henry Bourke, consultant knee surgeon, thank you very much indeed for that talk.
Thank you, Justin.